Now, just to follow Cicely Saunders' suggestions, I am presenting you one of our patients when he was admitted to our hospice ward with his young nephew and his wife, a painter from Chile. And just to give you a sense of what we do and a sense of the meaning of being here and talking with you. The meaning is in the patients, of course, not in ourselves and what we think in our careers and what we do. A homage to you all as hosts, but in particular to Irene Higginson, who invited me. I wanted just to recall, I will tell her later, then we met originally in 1994 at the conference in Bergen in Norway. It was the third EAPC Congress, European Congress on Palliative Care. And it was the time when I gave my first talk on Delirium, and she was very kind to express her approval to what I said, and I was a young doctor starting with this topic, and so I went on with this for more time, and that's why I'm talking with you today. Cicely Saunders, already in her early writings in the 60s, was highlighting that mental confusion, delirium we would say today, was probably a difficult symptom, more difficult than pain, to be evaluated, assessed and treated when she was commenting about her early experiences in hospice care. So we are perfectly in line with the Cicely's inspiration and thought as to work a little bit on delirium today. So one topic I want to highlight, and I'm not going to go very much in detail in this, but I think it will come as a sort of a product of what we say as a general observation that we can make. Certainly that delirium per se is a very interesting syndrome and symptom in palliative care because it bridges the interest of very many different expertise and areas of medicine in a way which makes the experience that we can have in delirium as palliative care specialist or palliative care field in a very interesting and independent aspect of the understanding of delirium, which certainly needs to have the contribution from other specialties, but it certainly also has the possibility to give contributions to other specialties and areas of medicine. The plan for what I'm going to say is to go through this in a relatively systematic way, from definition to interventions, going through a number of other topics. So the definition that we use today is the DSM 5th definition, very recently published, and you see that it points to a problem, a disturbance in attention and awareness, which is one of the ways we try to operationalize the concept of consciousness. Consciousness being the ability to be aware of ourselves and of the environment, and therefore the obtundation of awareness is certainly one of the main central aspects of delirium. So these two criteria has to be present. The short time period development time course of delirium as an acute problem. Sometimes we may anticipate is not so acute, particularly in geriatrics and in the demented patients. It can be a long-standing condition, different to differentiate from more long-standing condition, but certainly a change in the baseline condition of the patient, which tend to fluctuate during the course of the day and worsen or potentially ameliorate. Disturbances of cognition and perception are also associated. These symptoms or this syndrome is not explained by a pre-established dementia, so there is a differential diagnosis with dementia and with other psychological or psychiatric disorders, and there is evidence that this is a direct physiological consequence of a general medical condition to distinguish the syndrome from psychiatric conditions and to base the syndrome on what was previously called an organic brain disorder. Now the psychiatrists, they hate to use organic and non-organic, but however it's simple to say, and this is what is meant by this sort of metaphor that you find there. Now, to try to make it an operational concept, I found this description very interesting from an English psychologist some time ago, but I think it's a way of thinking about it. The ability to be aware of self and environment, consciousness per se, as the role of selecting and presenting to our consciousness the external and internal stimuli coming from our body, from the environment. You can think also that what is unconscious can play a role sometimes in regulating our awareness and our appreciation of what is real and what is out of reality. If you think of delirium as something which is breaking the rules, breaking the borders between these situations, you can understand how delirium will modify, will make it abnormal and pathologic your perception of external stimuli, internal stimuli, and sometimes mingled with something which is unconscious, sort of make it happen the delusional and unreal experience that patients can have during delirium. The way the brain is controlling our consciousness, level of consciousness, and sleep-wakefulness cycle is related to the structures which are in the more profound areas of the brainstem, the thalamus, and the way these structures are controlling our cortex, our cortical mantle, which is responsible of our ability to be awake, asleep, delirious, or in coma, depending on how this system is deranged. And therefore, there are a number of neurotransmitters that are playing a role here. We are not going into the details of all of this, doesn't matter, but just the fact that these are the areas that are at risk when something which is coming from outside or inside is creating a noxious insult on these structures and deranging the ability to maintain a normal state of consciousness and sleep-wakefulness cycle. Consciousness and awareness, you can also look at this concept in terms of what it is, the level of consciousness and the content of consciousness. We already said that consciousness means to be aware of what it is, the perception of ourselves, therefore to have a content on consciousness that we have to evaluate, and the content on consciousness can be deranged depending on what state is our level of consciousness. If you sleep, you have probably what it is considered to be a normal content of consciousness. You are in coma, the content on consciousness that we think is probably reduced to 0. This is what it is. And there are several levels of the level of consciousness between normal and being hyperactive, or being lower than normal, in which also the content will be changed. Same for the level of consciousness, which is 0 here, it's hyperactive here, it's somehow in the normal state here, which is a very, very peculiar situation of the vegetative states. And you can look at delirium as something which is in the between an abnormal state of consciousness and therefore producing an abnormal content of consciousness. The assessment of the clinical conditions is done by looking at the level of consciousness, cognitive functions, some very specific areas, and also some neurological aspect of the patient condition. Now we have specific instruments to look at that. And due to something which we will address immediately, which is the epidemiology of the syndrome, it is probably also a question that we have to ask to ourselves is if in a palliative care setting, which is any, should we have a specific and structured way to address the level of consciousness of the cognitive status of the patient because of the frequencies with which we will see in our experience cognitive failure and delirium. There are different instruments here that you can use, and there are then screening instruments that you can use, such as the nursing delirium screening scale. This, I think, is something that we can look more carefully if we want. The mini-mental state examination is a very popular way to address in a simple fashion cognitive function, and you can use it also as a screening tool if you want, provided you understand that this is a way to address cognitive functions more than delirium per se. So this would be also pathological in a demented patient, not necessarily a delirious patient. But if you use it for screening your patients, for monitoring your palliative care patients, certainly a change in this will, however, give you the sense that something is happening. This is interesting because it has been built to be administered according to nursing shift and on 5 different items, which are rated only as normal or abnormal, and by having only one of these in the abnormal side, you flag the patient as potentially maybe manifesting delirium. The differential diagnosis that have to be made between delirium, dementia, potentially acute psychosis. This is not totally rare in our patients, maybe not common, but not absolutely so rare. People with previous psychiatric history, which may have very strong personality reactions to the difficult situations they are living in. They may look confused, but they are really maybe in a sort of a catatonic state because of a psychiatric condition. Seizures is a more also not totally not that common, but again, not totally rare and probably more common than acute psychosis. You have to be aware that some cases of patients which are not convulsing, not having a classic seizure disorder, they may have a seizure condition which does not recover, so that is called the status epilepticus, and be looking like confused or delirious. Such in this case, this is a convulsive status due to one particular chemotherapy drug, and the patient with this condition looks exactly like a delirious patient with some myoclonus, confused, responding in an irrational way to questions and so on. One reason because delirium is important in palliative care is the frequency with which we see this complication in our patient. In this table, I made a very simple qualitative comparison between different populations, and you see that in the elderly, certainly delirium is very important because of the prevalence, and in the incidence, usually these are incidents looked at after admission to hospitalization for different reasons, and also in oncology. In this different palliative care setting, we see that there is a tendency to increase of the frequency according to the patient condition. But better than my own is this paper by a group of nurses from Australia, and which is a systematic review of the delirium literature in palliative care, and by making an analysis of a number of papers, they were able to demonstrate in this nice graphic representation that according to the setting, prevalence of delirium on admission in specialized palliative care unit is already relevant. The prevalence during admission increases. The incidence is a little bit different because these are the new cases occurring during admission, but it tends to be a variable number, and the prevalence tends to increase while death approaches, you see, which is again an important amount of information there. The impact of delirium on our patients and family is something which has been seldom looked at It is difficult, of course, because how can you ask a patient with delirium are you bothered by delirium? Is that distressful? No? That's a very stupid question sometimes, because at least. But it is an interesting idea. And it was looked at by Bill Brightman from the Memorial Sloan Kettering Cancer Center in New York in an intelligent way, I think, by asking people who were recovering from delirium how was their experience or their recall of their experience, if they had any recall of it. And interestingly enough, many patients do not recall. And the patients who do not recall their experience are those with the more severe delirium conditions. And this is reasonable because the brain is working so poorly that they are not even able to be minimally aware of what is happening. But the most interesting side of this is that some they do recall, and this is acceptable, because if we think that there is a failure of awareness, a failure of the level of consciousness, this doesn't mean that the failure of awareness or consciousness is so profound not to make it possible that the patient is partially aware of what is happening. And this awareness can be very distressful. In fact, in this study, the patient, 53% could recall the episode. They asked on a scale of distress from none to very much if the experience was indeed distressful for them. And the results are these, that 80% reported moderate to severe distress. And interesting, they were asking also the spouse or the caregiver how they were distressed by seeing the patient delirious, and nursing staff how they were distressed for caring, for looking at the patient, looking after the patient who was delirious. And you see that certainly distress is very high for the patient, is higher also for the informal and formal caregivers. Some predictors of distress are interesting: the presence of delusions, the presence of illusions, hallucinations were more importantly predicting the level of distress. So this is also a reason for reinforcing the idea that we need to treat delirium. We need to be able to control delusions and hallucinations if possible. The impact of delirium on the families, I think it's an interesting topic which has been looked at by a few authors now, not very many, but it's interesting to look at the fact that specific measures of anxiety were very high in caregivers who were looking at their dear ones with delirium, and the partial part of this anxiety was even detected at long time intervals after the patient died. And Morita in particular also has published a very interesting article in which he gives details of what types of responses and behaviors on the side of the caregivers were perceived by the family as helpful and important when their dear ones were in a delirious state. A very interesting article, I think, confirming some simple statements, such as saying that the way care is given is very important for the others. Another important impact is that delirium has an impact on short-term survival of our patients. These are three groups of patients with a different prognostic risk. Patients with advanced cancer, according to one prognostic score, you see the best prognosis, the intermediate prognosis, and the worst prognosis at you see at 3 months. This is a 3-month period. Most patients have a much shorter prognosis, you see. And to be delirious or not to be delirious, these are delirious one, and delirious one, worsen the short-term prognosis in all the three groups of patients. So delirious is certainly demonstrated as an independent predictor of survival for our patients. Therefore, it's an important aspect to evaluate in the ability to understand if the patient is coming to a shorter prognosis, if death is approaching. Pathogenesis and etiology, this is also extremely important. The fact that multiple factors are almost always present as potential etiologies. This is something we have to think about, how predisposing factors and concurrent incident factors can play a role. And this has been explained in several ways. We know that mostly delirium is due to diffuse metabolic toxic factors which are impacting on those cerebral structures that we looked at before. A single etiology is almost ever found. The difference in cancer is that the presence of structural brain lesion is not so uncommon in the cancer population because of the nature of the disease. While if we talk of the geriatric population, if we talk of the general medical population, the postoperative population, certainly most cases of delirium, you very rarely, delirium is almost the hallmark of a non-structural brain situation, provided you exclude in some cases that there is a structural brain lesion. So it's always something you have to think about. Very interesting studies from the geriatric literature about were able to demonstrate that there is an interaction between predisposing and incident noxious factors. And this is a way to think of what it is a predisposing factor, vulnerability, predisposing factor, and the external or changes that are happening. So this means that a man with dementia and 80, 90 years admitted to hospital for a femur fracture, for instance, if you give to this man 1 drop of diazepam, which is something which would never do anything to any of us, can combine a very high vulnerability with a small drop which makes the vase pour, as you say. No? This has been demonstrated by statistical methodology quite nicely. This to bring all of this together, predisposing factor that we can find different type of patients, lesions to the brain or not, dementia, age, cognitive failure, very important, the structures that are there, other factors that are coming from outside, toxics, metabolic, unknown, we don't even know what it is really playing a role in the pathophysiology of these cases. This is coming from the literature, factors that have been looked at, the red heading are mine to try to give an order to what we find, and again, the importance of advanced age and previous impaired cognition, dementia in particular, but also clouded dementia, a condition that may be not clinically evident, which becomes evident when the patient has a complication, and when the patient is confronted with an opioid or with something else, or with a deteriorating general condition, as we say, functional impairity, severity, etc., proxy of what it is a progressive disease, specific factors. We have to, as all the list of the possible metabolic changes, including a vitamin deficiency, and the factors that we are responsible of with our therapeutic interventions. Structural causes of delirium due to cancer, we don't need to go into the details of these things, and also in cancer sometimes you can have things that are not due to cancer, infarcts to the brain, or toxicity or specific chemotherapy producing lesion to the brain that can present as delirium. But of course it's very important that we always look very carefully at the medication that we are giving to our patients, because these medications have all a risk to contribute to cognitive impairment and potentially to delirium, particularly by impacting on frail patients, on elderly patients, on patients with some degree of cognitive failure, and so forth. And it's too complicated to list all the drug interactions that are possible that may result in unexpected toxicities by combining these drugs together or with other drugs, with chemotherapy drugs, and so forth. The serotonin syndrome is one of the examples of these potential very toxic complication, and but we don't have time, of course, to describe it in detail. What are the interventions that we are going to place to treat or to reverse delirium or to prevent eventually delirium, if possible at all. I will make only a few examples to finish with this overview, just to give you the time to think about it and make questions. Interestingly, from the study of Leonard more recently, but also from the study of Peter Lawler in Archives of Internal Medicine more years ago, it is demonstrated that a number of cases of delirium, even in palliative care, are reversible. And not surprisingly, in the study by Leonard and MacLeod and others, they showed that the unreversible cases, the cases that are not reversed by delirium, are those for which delirium is often a sign of impending death, which is not surprising because the cause of delirium is probably the failure of organs and of vital functions, which goes together to abbreviate the patient life. But however, the possibility that we can reverse 50% of the case is an important observation. How to check, how to be careful enough to reverse cases where it is possible depends on several issues. In the literature you find several observations. For instance, logically, delirium which is associated to drug toxicity is one of the more easily, so to speak, and it's not very easy, but I mean it's more easily than the rest, situation where you can reverse a case and so forth. Prevention, we will see one example about this. Reversible causes, pharmacological management. I have only a few very brief observations, highlights on these, and then we finish. Reversible cases, if delirium is due to opioids, you can reduce the dose, not rocket science of observation, I have to say. You have to switch, you can switch the opioid, you can switch the route, you can treat the condition. Then you are left with that, I think. This is very important, I think, and an amazing demonstration on how in geriatrics, indeed, it is possible to prevent delirium by changing the pattern of care of the elderly when admitted to a hospital for a medical condition and providing a delirium prevention strategy to the management of the elderly, which includes these number of peculiar interventions, and we do not have time to look at them in detail, of course, but Sharon Inouye, this was done at Yale University in the United States, I think, and they were able to demonstrate in a nicely conducted randomized trial that the percentage of incident delirium was reduced in the group of patients exposed to the preventative strategy. Somebody tried to apply this also to palliative care. I think Pierre Gagnon published one paper, which was not successful. I think it's a relatively ambitious hypothesis, because the conditions that we are facing in our patients are much more difficult to modify than those that you can have in the elderly, relatively less ill patients. But certainly there might be some ways to be more careful, for instance, with benzodiazepine use and so forth, that might result helpful, and certainly an area for research. Pharmacological treatment is what we are left with usually to control agitation, to control delusions, to control hallucinations, and certainly thinking of why we use drugs in patients with delirium, we should also remember that patients with hyperactive deliria with those that have hallucinations, delusions, all that, more easily to identify, and those are the ones that we are more often treating. The fact is that in palliative care, more patients with hypoactive delirium are usually seen. And it is not a given that the patients with hypoactive delirium do not deserve or do not benefit from treatment if we identify them correctly. So we go back to the idea of screening, evaluating, and assessing carefully, which is probably the first measure to take to improve patients' care. Then you can decide what to do after you know that something is happening. If you don't know, you probably don't do anything. Pharmacological treatment is based on evidence which are reviewed by several authors, which were evaluated globally as relatively poor. We all know that haloperidol is still the first-line drug together with other potential alternative neuroleptics to control delirium. The control of delirium as a two-step, I think, approach. A conservative approach is to use major tranquilization, which is the use of neuroleptics and haloperidol. Tranquilization means to control the symptoms of delirium, not to lower the patient consciousness level, not to sedate the patient. Sedating the patient is second step level when you cannot achieve control, and it is a less conservative condition, because you are sacrificing the patient consciousness level to control the patient behavior and control the patient mental situation and potentially, we hope, mental suffering. But the first step is to use the least sedative drugs in the choice of the neuroleptic, which is indeed haloperidol, and others such as risperidone, olanzapine also. Quetiapine is already a more sedating drug. The combination of benzodiazepine is something we have to use often, because we are not enough successful in using neuroleptics to control the patient's symptoms, and we would combine a more sedative drug such as benzodiazepine, or to choose a more sedating neuroleptic such as chlorpromazine. Levomepramazine is popular. I think you call it metotrimeprazine, is that right? Metotrimeprazine, I think. Okay, it's the same of levomepramazine. Quetiapine is more modern drug, an interesting drug because of more sedating, useful for helping during sleep at night, for instance, to control aggressive behaviors, hallucinations, agitation, and so on. Sedation is an option to control delirium. Sedation at times when you treat delirium in the patients who is dying is overlapping with what we call palliative sedation. But I would try to make a more heretical observation, which I would say, which is that when we are classifying the patients for palliative sedation, when palliative sedation is associated with delirium, I don't think we are making the same observation that using palliative sedation for people with acute symptoms, with dyspnea, with severe, who are in a normal state of consciousness and experiencing terrible terminal conditions. I think it's a totally different situation because of the fact that you already have an altered state of consciousness. You already have a condition which you would treat, however, sometimes with sedation, even if the patient is just in a postoperative phase of a femur reconstruction, for instance. And therefore, I don't see that much this big specificity of being palliative, of being terminal sedation for that particular group of patients. That can be considered an heretical observation. And for those who would like to read more about delirium, there are a few books, some of which can be also a very interesting present for Christmas, I think. And they may also help my kids to get better Christmas presents because of the copyright revenues that are coming from selling the book. So this is the sort of the last observation. And this is the seminar we are having in Milan next week. And also Irene is coming at least for the conjunct meeting to that. and part of the seminar, of course. We are not talking about delirium in this seminar, but I think we should include more delirium and delirium science also in the interest of the European Palliative Care Research Center. I've been using the European Palliative Care Research Center slide in this presentation to give you the opportunity if you want to get informed about this network of research, which is also organizing this seminar in Milano next week.
We're part, actually the CSI
Sure,
is a partner.
sure. In fact, the Cicely Saunders Institute is also another of the institutions who are contributing to the PRC together with Milano and others. So this was my brief talk on delirium.